Okay, so around eight stage, I saw the sign that the age was the second third stage. Just like normally you think that at the same time, my brother was a second at the 7 in the hospital at the time. My mother, my husband, and my wife were very excited. They said, "Hey, it's a baby boy." They said, "Yes." Every step, they said, "Yes." And they were working on him. All his my wife has a name for him. So my brother also spent that listen. That's yesterday, that was they decided that actually they thought that my report might have checked before sending it, so they wanted to quickly get it out. They weren't according to me the amniotic fluid is what sounds to be. It has somehow entered my bloodstream. And once the amniotic fluid touches the blood, it acts as an anticoagulant. So my blood stopped coagulating and I was born. My brother was able to get 2 minus. All of this is before I reached positive. I'm told that when the nurses were giving the vaccine, only 2, because there was what my husband's cousin was a doctor at the time, so he also called him, and he also asked. So they based the 4 pints and by groceries, a lot of prayers, a lot of prayers. It was a lot of place that I came back to life. I mean, in this country, today, 8 women die every day from childbirth. And out of those 8, 2 die from hemorrhage, blood related. So it happened. I'm sure that it can be really easy in some families.
National Blood Service Ghana is an agency of the Ministry of Health, mandated to ensure the safety and adequacy of blood and blood components, making it accessible and affordable to patients in all hospitals in the country. So it does this through its operational areas, through education of blood donors, through mobilizing them, collecting the blood, testing, screening, also preparing blood, storing, distributing to hospitals as and when they need the blood.
Roughly, if I start from the country-wide, we know that WHO estimates that usually 1% of the population is the country's blood needs. So that works out to about 250,000 units in every year.
The National Blood Service is supposed to supply about 200 units of blood every day. Even Korle-Bu alone will supply about close to 150 units of blood to Korle-Bu. Not to talk about other hospitals that we supply.
Our voluntary donations are about 45% countrywide, and I think that our aim is to have 100% voluntary donors.
With all the scientific developments that we have, man has not been able to replicate blood. You can only get blood from a fellow human being. Therefore, it takes a lot of sacrifice. It's man that donates blood.
I think that the biggest challenge that we face is increasing blood donation as a way of life. I think that's the concept has sunk very well into the public domain.
Blood donation is safe. Professionals who are trained in the process. So they take you to a good history. A good history is done. It's
process. You can go back to work. You can do whatever you want to do, except that if you are operating maybe a machine which will take too much energy out of you, we don't advise that after donation you go and visit those machines.
When you are saying your name, who must be between 80 or 60 years, they should be of sound mind, male or female, and everybody who is well, when you must be quite well, be able to donate that. Blood must be collected to the blood bank, you must test your blood, you must screen the blood, you must store things that are born, and that comes at a cost.
And for now, it's respected by cities. Other facilities are charged much higher than that, but we need to bear in mind.
Good evening, fellow brothers, sisters, gentlemen, and ladies, confined here to this very important public lecture. Yes, this public lecture was organized in relation to the World Blood Donor Day, which is scheduled for Saturday, 14th of June, in commemoration of one person, we call the father of that transition, the person of Karl Landsteiner. And the theme for this year is Safe Blood for Steady Mothers. So this evening we gathered here to have this lecture in respect of that theme, to create awareness of what's happening in our country today. And without much ado, I want us to bow for a word of prayer for the opening prayer. Shall we pray? Our gracious and merciful King, we thank you so much for this day. We thank you for the victory showers. And we thank you for our lives and our health this day. We thank you for this gathering, and we pray that your Holy Spirit be with us. We gathered in order to know what is happening in terms of our mothers in relation to life that we need to fight through delivery. We pray that you give us retentive memories and understanding. And we pray that you will keep our resource persons with adequate wisdom so that they can impart this glory unto us. Pray for your divine intervention. We'll have peace and tranquility in this place. And our future all, only one name shall glorify. Thank you for an answered prayer. It was asked in the mighty name of our Lord Jesus Christ. Amen. Amen. Please, John Peter, I'm the MC for the occasion. And we have very important personalities in our midst. In our chair, we have to get somebody to introduce our chair to us. The first is the so first, to come and introduce our chair for us. Let's welcome him with a round of applause.
You are all welcome to today's program. Our chairperson is a lawyer and a human rights advocate. She is an advisory member of the International Consortium for Realizing Reproductive Rights. She is known for her strong passion and dedication towards advocating for human rights and gender equality. Our honorable chairperson until recently was the chief Executive Director of the Human Rights Advocacy Center. Having worked for years as the Regional Coordinator for the Commonwealth Human Rights Initiative, she has a Bachelor of Law from the Ghana School of Law, a Master's in Law, Human Rights and Democratization in Africa from the University of Pretoria, South Africa. Our chairperson is currently the Minister for Gender, Children and Social Protection. Audience, please help me in welcoming our distinguished chairperson for tonight's lecture, the Honorable Miss Minister Nana Oyelita. Please give her chairperson, please, audience, your chairperson.
Audience, my name will introduce me. Thank you very much. Thank you. Distinguished persons at the high table, ladies and gentlemen, I'm very happy to be here because as a little girl, I walked across Adanu Park all the time because I spent the first 22 years of my life at the Korle-Bu Hospital with my mother, so I'm happy to be back on familiar grounds. But more importantly, I'm happy to be part of this very important public lecture to celebrate the World Blood Donor Day. Because several women die when they are performing a natural function, a natural biological function, and that function is when they're giving birth. This should be a moment of joy, not only for the woman, but for the family. Sometimes, unfortunately, it ends in tragedy because we don't have a lifesaver that is blood. When we look at the statistics and the data, you've been given a sheet. It says that 289,000 women died from related complications to pregnancy and childbirth. 62% of that occurs in Africa. And severe bleeding is the leading cause, accounting for 24.5%. In Ghana, it is the leading cause for women dying through childbirth. And sometimes they are not even able to get to a hospital or to a healthcare facility for assistance. And even when they do, sometimes they do not have the blood supply to be able to help them save a life. We also know, I was just asking those at the high table, your colleagues, that do we now have a black policy? And I'm happy to learn that we have a black policy now. Because when I was doing research on the legal and policy framework for reproductive health and reproductive health, I realized one major gap in our policy framework was that we didn't have a black policy. Now that we have a black policy, the question is, to what extent do we ensure that at all our healthcare facilities we have adequate blood supply? So today we are here to hear Dr. Richard Adanu lecture us on some of these very critical issues in terms of safe blood and saving mothers. Blood transfusion is very important, and I'd like to congratulate the Blood Bank for the work they're doing, engaging with the private sector and also engaging with Ghanaians and the community at large, sensitizing us on the need for us to donate blood. I believe that this has been very successful, and I'm happy that today we're focusing on how we can save mothers. As you know, I'm from the Ministry of Gender, Children and Social Protection, and this is also very critical for us, because when we have adequate blood supply, we will be able to save mothers and ensure that mothers go through this natural biological function that God has asked us to perform without leading to death. It's very important that we focus on saving mothers and therefore saving lives. And I'm happy that this public lecture has been organized, and at the end of the day, I'm sure we will go back with more knowledge, and also Dr. Adanu will share his experiences with us as Director of School of Public Health and as a fellow pupil of Richards School, where we were colleagues at Richards School also. So we're very grateful, and I'm sure the MC will help me to check this to a very successful end. Thank you for the attention. Sorry, there'll be a short documentary after. So we'll wait for the documentary.
Thank you very much. Can we give a hand for round of applause? Now, we are going to have the welcome address.
Because in the pregnancy of my last in 2003 that I had this incident occurred. So around midday, I saw the signs that the baby was due. Between the second and the third stage of the delivery, we just have 5 minutes. Normally, it should take at least 15 to 20 minutes. But by God's grace, the baby came out. Now, at the same time, my brother was a surgeon at 37. The baby was at the time. My mother and my husband had arrived. They were very excited. They said, "Hey, the baby born." They said, "Yes." Like every the baby, they said, "Yes." They were from him. My God is not where your wife has a bit of a problem. So my brother thought she was the person. Used to the economist. And they decided that I was going to They thought that my uterus might have ruptured before sending it, so they wanted to quickly get it out. They wanted to have 2 minutes for the call. What is it? The amniotic fluid is what surrounds the baby. It has somehow entered my bloodstream. And once the amniotic fluid touches the blood, it acts as an anticoagulant. So my blood stopped coagulating and I was falling. Fortunately, my brother was able to get 2 pints of blood in 37 minutes. All of 37 had only 2 pints of my blood. The whole average was there. And I'm told that when the nurse were giving the medicine, only 2, because it was short. Woefully inadequate. My husband's cousin was a doctor at the hospital at the time, so and he also arranged for some blood. My husband went about 2 pounds. So they visited the 4 pounds to me. And by God's grace, and a lot of prayers, a lot of prayers. It was a lot of grace that day. I came back to life. I mean, in this country, today, 8 women die every day from childbirth. And out of those 8, 2 die from hemorrhage, blood-related incidents. So if we have blood, I'm sure that we can really save some of our mothers.
The National Blood Cell is an agency of the Ministry of Health mandated to ensure the safety and adequacy of blood and blood components, making it accessible and available to patients in all hospitals in the country. So that is through its operational areas, through education of blood donors, through mobilizing them, collecting the blood, testing, screening, also prepare components, and storing, distributing to hospitals to access the blood.
Well, if I start from the countrywide, we know that WHO estimates that usually 1% of the population is the country's blood need. So that works up to about 250,000 units every year.
The National Blood Service is supposed to supply about 200 units of blood, every day. How to? Within Korle-Bu alone, we supply about close to 150 units. Not to talk about other hospitals that we supply.
Our voluntary donations are about 45% countrywide, and I think that our aim is to have 100% voluntary donors.
With all the scientific developments that we have, man has not been able to replicate blood. You can only get blood from a fellow human being. Therefore, it takes a lot of sacrifice in human life to donate blood.
But I think that the biggest challenge is that we face as Ghanaians embracing blood donation as the way of life. I think that's the concept hasn't sunk very well into the public domain.
Blood donation is safe. It's safe because there are professionals who are trained in the process. So they take you to a good history, a good history is done, a clinical proper screening is done. It's nothing, there's no risk.
After the process, you can go back to bed. You can do whatever you want to do, except that if you're operating maybe a machine which will take too much energy out of you, we don't advise that after donation you go and operate those machines.
The person who has been advanced in between ages of 70 and 60 years, it should be of a sound mind, male or female, and anybody who is well. I mean, you must be quite well yourself, that's in good health, to be able to donate blood.
Many people argue that blood is donated freely, so why is it that when the patient needs the blood, they have to pay something for it? And I keep saying that look, the blood that people donate must be seen as the raw material.
Blood must be collected in the blood bank. You must test your blood. You must screen the blood. You must, store the reagents that are bought, and that comes at a cost.
And for now, it is 35 Cs. Other facilities are charging much higher than that. But we need to bear in mind that sometimes when a person needs blood, he needs 2 units, 3 units, 4 units. And so when you charge too much for blood, then it becomes a problem because many people can't afford it.
I woke up that morning, I was fit like you. I had no idea that I would end up with 4 pints of blood. My case was extreme. Most people just need 2 pints to survive.
I know the spirit of volunteerism needs to be rekindled in this country. It used to be quite a lot, but I think that we need to go back to that. People should give themselves voluntarily to help those who are in need.
The National Blood Service has a blood drive at the Accra Mall the last Saturday of every month. And I think this would be a very good way to support them.
A person can donate blood voluntarily every 4 months. And I think that if more and more people do this, we'll find out that suddenly we don't have any problem of acute that should be seen done.
This is a national assignment. So anytime, anywhere you hear of blood donation, please respond.
Because the way it works, there's no way I would ever know who saved my life. But I can assure you that you have a special place in your hearts. Because of people like you, my children are not motherless. I'm able to attend their PTA meetings. I'm able to have little parties for them when it's their birthday. And they've grown up feeling the love of their mother.
That is very intriguing and interesting thing that you've watched concerning blood and blood donation. Yes, we have some important lyrics in our midst. I would like to introduce them then before our main speaker comes. And we have our head or the director of the National Blood Service, the person of Dr. Justina and Sam. Just that I can't wait for them to go. Then we have the head of the Saudi area of this place where we are sitting now, the head of this place. And he's the person of Dr. Paul Mensah. Dr. Paul, you are the owner of this place, and you need to welcome us before you do anything. So I hope we'll call on you so that if you can say something about what have you seen, Saudi Arabia Blood Center, what at all do you hear? If you can say some things, but from your own mouth, maybe it will be so that we will all decide to be blood donors, or to blood donors. Dr. Paul Mensah, let me give us a welcome address.
Thank you very much, the Honorable Minister of Women, Children and Social Protection. Our main speaker will be introduced at the appropriate time. Press men and press women hearing that our main collaborators and supporters, dignified invited guests, ladies and gentlemen. A friend called me yesterday, and apparently this documentary I've been showing on Viasat, and he says that's a very, very touching documentary. And after watching it, if there was a donation there, he would have lied on it and donated immediately. And I think that it's one thing knowing and it's one thing actually doing. And we are hoping that the knowledge that we acquire will be translated into practice, because that is what actually saves lives. It is a well-known fact that blood is the very life that flows through us. Many of us sitting here may never need a blood transfusion. And yet, there are some people who may need a blood transfusion at some point in their lives. The people who need blood transfusions are no different from us, because the reasons why people need blood transfusion is for things like having been involved in an accident, or having to undergo surgery, or even severe malaria in children, and so on and so forth. The journey of pregnancy, which many men look forward to, and is supposed to bring joys untold to many families, can also result in blood loss, warranting the need for blood transfusion. In Ghana, many women die because of the lack of blood when they go through delivery. And many of these instances are because of untoward blood loss during delivery. The WHO estimates that about 800 women die from pregnancy and childbirth related causes. And over half of this figure occurs in sub-Saharan Africa. This is the number of women who die on a daily basis around the world. It's a surprising statistic. And I dare say that if 800 women of different nationalities had died through an airplane crash, it would assume a disaster of global proportions. And yet, yes, that we are having to contend with, especially in sub-Saharan Africa, Ghana being no different. In view of this, it is understandable that strenuous efforts are being made to curtail this anomaly. And that is why we think that the theme for this year's World Blood Donor Day is very apt. Save blood for saving mothers. The safety of blood starts with the adequacy of blood. And the adequacy of blood starts with us getting more and more people to donate blood so that we can move away from the family replacement system that so bedevils the country. On behalf of the National Blood Service, I warmly welcome all of you here to today's public lecture, which is just one of many activities that have been lined up for this year's World Blood Donor Day. And I wish you all a very good evening and very fruitful deliberation. Thank you.
Thank you very much, Dr. Korle-Bu. Yes, I wonder why our mothers are dying in sub-Saharan Africa. supply in Europe, elsewhere. They are not dying like that. I once heard an obstetrician. He worked in Europe for 5 years. He said, observed only 2 maternal deaths. Now, why is that? The only problem, or once identified problem that we see is lack of blood. Can we turn the scale so that our women will stop dying? If all of us will turn out to donate blood, I think we are going to emulate what is happening in Europe today. Now, on our program, this is the time that we have to listen to a very important speech that we got here. And I'll call upon a lady, Miss Lydia, to come and introduce our main speaker for today. Let's welcome her in front of our guests.
Pleasure to introduce our guest speaker for tonight's lecture. Our guest speaker is a seasoned researcher in the field of maternal health. He is also a specialist in women's reproductive epidemiology and maternal health. His research interests include obstetric and gynecological disorder in Ghana, family planning, cervical cancer screening, and maternal injuries. He has worked as a specialist at the Korle-Bu Teaching Hospital in Ghana since 2001 and is currently the Dean of the School of Public Health, University of Ghana. He is also the director of the Mamaye Ghana team. Mamaye Group focuses on using strategic combination of evidence, advocacy, and accountability to save lives in Ghana and other African countries. Our speaker for tonight graduated from the University of Ghana Medical School and completed his postgraduate training in obstetrics and gynecology at the Korle-Bu Teaching Hospital. He later obtained a master's degree of public health from the Johns Hopkins Bloomberg School of Public Health as a Gates Scholar. Madam Chair, audience, please help me welcome Professor Richard Adanu.
Good evening, everybody. And thanks for that introduction. It's really nice to be back here. I think I should start to say like Honorable Minister, isn't it? Honorable Minister, Director of the National Blood Service, distinguished guests, ladies and gentlemen. It's nice to be back here, and I was pleasantly surprised. I mean, I actually went through a long adventure getting here today. The invitation letter I had said that they mistakenly said something after the British Council. So I left at 4 o'clock and got to the British Council, and I didn't see anything like blood around the British Council. So I called and I was told that, oh no, it's out here. And I was told it's at the new blood transfusion center. But I felt I knew Korle-Bu better than the person who was talking, and it was like new blood transfusion center. So I drove to the old place, and there was nothing like blood around there. And then one nice lady coming out from the hematology department said to me that, oh, there's a new center, you've got to drive out and by the commercial bank. So I drove and got to the commercial bank and didn't know how to get here. So I called again, I was given direction. And I was quite happy that since I left here, there's something this prominent and new that's happened, which I had to take time to find. And I was talking to Mr. Tete and told me that this is a collaboration between the government of Ghana, CDC, there's Northern Fund, and Nordic Fund, and all that. And I think it's very impressive. It's really impressive. This is much nicer than the old blood bank, where I think I've covered a number of miles between the maternity block and that blood bank. But this is a really nice place to come to. So I'd like to say big congratulations to all those who contributed to this. It's a fitting place for what we have. So congrats to everybody. I'm going to be talking about safe blood for safe motherhood. And a number of the things that I'll be saying have actually been said in the documentary and also by Dr. Paul Mensah when he spoke. But we'll run through it. And this is I move the slides. So I should do it too. Okay. So this is how we're going to run through this. I'm going to talk a bit about blood in medical practice. Then talk about what we mean when we say safe motherhood. And I'll spend some time talking about maternal health in Ghana. What are some of the statistics that we have concerning maternal health in Ghana? Then we'll end by looking at how we can get blood to achieve safe delivery. Is that coming up? So like I said earlier on, when it comes to blood is the life that flows through us. Blood is the fluid that flows through our veins and that gives us life. And blood has many uses. And there are many things that blood does that keeps us alive. One of the things that blood does is that it carries the nutrients that we need from the source of the nutrients to different organs in the body. If there's a problem with getting that up, we just bring the computer up here, because I'll soon run out of memory. And so blood carries the nutrients from one point of the body to other parts of the body. If we don't have blood, one reason why we wouldn't survive is because our different organs are going to die because they're not going to be nourished. Another thing that blood does is that it carries the blood gases that we need. I mean, we breathe in oxygen. Oxygen dissolves, to put it that way, dissolves into the blood, and then the blood carries the oxygen from the lungs right around the body. And that gives us the oxygen that we need for the different processes that happen in the body. Then, when these processes happen in the body, we all know that we breathe in oxygen and breathe out carbon dioxide. But then as the processes happen in the rest of the body, carbon dioxide is one of the waste products that comes out alongside other waste products. And the blood carries this carbon dioxide also away from the different organs in the body and brings it back to the lungs, and then we breathe that out. So blood is actually very crucial. Even the simple breathe in and breathe out that we do, if there was no blood to move things around, you take the oxygen in and then you still die anyway, because oxygen is not going to dissolve anywhere for it to be carried to the appropriate organs in the body. So blood is definitely very crucial. Blood is very crucial. And in medical practice, when it comes to blood, what do we do with blood in medical practice? The thing that we primarily do with blood is to replace blood loss. I mean, people might be involved in, say, a road traffic accident, and due to that involvement in a road traffic accident, the person might lose blood. And when the person loses blood, blood is lost very fast in a short period, there is a need for us to replace that blood. So that's one of the uses of blood in medical practice. The same blood, sometimes when a person is going to do surgery, just as a backup, because when you do surgery, when the surgeon cuts through different parts of your body, there could be bleeding. So there's a need to have blood as a backup. So just like how we are encouraged to save, it's so that you save in the event of a rainy day. So the surgeon also likes to have that blood by him in case he runs into a rainy day when he's operating. In case there's sudden loss of blood, then that blood will need to be replaced. So that's another medical use of blood. Right? Let's not go up with that. Yeah, go. So when it comes to blood, how do we get blood? I mean, in the documentary, we heard about or said that despite all the advancements that man has made, despite the massive increase of knowledge, despite the cell phones becoming as complicated as ever, we have not been able to create blood. We have not been able to create blood. So I remember times when I used to work at the maternity block, we would have some people who counsel them and tell them that there's a need for blood. Either they're coming in for surgery, or the woman is pregnant and will tell her family members that there's a need to donate some blood. Then somebody would ask, and it was a regular question, that can't we buy the blood? And once in a while, when I got a bit mischievous, I would say that, well, yes, we can buy the blood. It's probably sold in the market out somewhere. Why don't we go out and buy blood? And the person is looking at me like, no, I mean, it can't be, it's not sold. I said, yes, blood is not sold. Blood is not sold. Blood is given by people. Blood is given by people. What's up there? Blood is given by people. So people donate blood. And when people donate blood, then that blood is used. Okay, so let's just start there. So and when blood is donated, one of the ways that blood is donated, which we tend to do a lot of out here in medical practice in Ghana, is through what we call replacement donation, where, let's say, a relative of mine is coming in for surgery. So because my relative is coming in for surgery, I come over to the to the blood service or the blood bank and I donate blood. Not because the person will definitely use that blood, but just so that it serves as a safety net. Serves as a safety net in case the person needs the blood during the surgery. In case the person needs the blood during the surgery. So that's called replacement donation. It is not that the blood that I give is the same one that's going to be given to my relative if my relative needs the blood. No. It's just that if blood is given to my relative, then this blood that I've donated goes to replace it, so that there will always be blood in the bank. Now, the truth is that if we depend on replacement donation alone, we would not have enough blood. Because some people are going to need blood urgently. They're going to need blood urgently, and like this person going for an operation, the person knows that I'm having my operation next week. So then somebody can donate blood in advance. When a person is running across the street, nobody plans to be hit by a car. Somebody gets up and says, okay, today I'll eat, I'll drink, then I'll get hit by a car. So let's donate blood in advance for it. Is there anybody who does that? I don't think so. So there are those kind of emergencies and people who need blood. So replacement donation donation alone will not help. So there's a need for us to think about voluntary blood donation, where people on their own, like that can be done 4 times in a year, people on their own would get up and come to the blood bank and donate blood, so that in case blood is needed, that blood can be used. So that's an important way by which we can get blood. Now, when we choose to donate blood and then also give blood to other people, it's not as if it is totally free of risks. There are risks involved in blood transfusion. Sometimes, if you take blood and give to another person, one thing that could happen is that an infection could be transmitted. If I have an infection that is in my blood, and that blood is given to another person, then there will be transmission of that blood-borne infection from one person to the other. And 2 serious ones which I have up there are hepatitis and HIV. These could be transmitted through blood. And also, the thing about blood is that we all have different types of blood, put it that way. There are different blood groups. And some blood groups cannot mix with other blood groups. So if we give a person a blood group which the person is unable to, let's say, to handle in his or her body, then there will be a reaction, a transfusion reaction. And that transfusion reaction could lead to the death of the person receiving the blood. So, I mean, just in case anybody is wondering, why do we have this big facility? All that we are saying is that collect blood and give to another person. We have this big facility with all the services that we have, so that this kind of thing will not happen. That's why we need a well-equipped facility when it comes to dealing with blood. And so to avoid the risk, those are some of the things you saw in the documentary. All blood donors are screened. In the first place, I mean, you're screened to make sure you are healthy before you donate the blood. And after the blood is donated, the blood is tested. I mean, they don't say that, well, we screen the person is healthy, so we just take the blood and we pass on to another person. After the blood is collected, that blood is tested. And some of the things that you saw at the time were showing the processes without the commentary. The blood is tested, then the blood is grouped. They get to know what type of blood it is, and that is clearly labeled. So then, if I come over now and I need blood, before I am given blood, my blood is taken. Even if I know my blood group, I mean, nobody leaves anything to chance. My blood is taken and is tested, and my blood group is found out. So my blood group is found out before a decision is taken as to which kind of blood to give me. Now, even though when you go to school, whether it's medical school or nursing school or whatever, there are ways by which we know which blood group can receive which kind of blood. So you could just see a person's blood group and say the person will receive this other blood group. That's what, in the early parts of medical school, we actually thought that was all that it was. You know the person's blood group, you just go and pick and say, get this one. But it doesn't work that way. Because when there are other reactions that can happen, even if the blood I'm being given, my body can generally take it. There could be certain things in the blood that my body would not be able to handle. It's not just the blood group agreeing with each other. So then there needs to be some tests done in the lab, mixing the 2 bloods and being sure that when this happens, the blood of the person, the blood that's been given agrees to the person who's receiving the blood. Now, all this is not just done and then we say the blood is good get. There's a lot of paperwork that goes with this. A lot of paperwork. You've got to document all this, and things are signed, forms are filled. Before you go give the blood to the person, you check through these forms and make sure there's the right thing that's being given. A lot of paperwork that when you're a house officer, you kind of like wonder, this a terrible waste of time. The laugh, people don't know how serious the matter is, but the truth is that they know how serious the matter is. That's why they take that much time to make sure that the blood that goes to a person is the right one, to make sure that blood is safe. Safe blood. That's what we need to give to people. They're going to next slide. So when we say safe blood, what do we mean? We mean that the blood is free from all infections. The blood is the right type for the person who's getting it. And there's no reaction between the blood that we are giving and the person's blood, and that's safe blood. And everybody who needs blood needs safe blood. But for this World Blood Donor Day, we're talking about safe blood for saving mothers, safe blood for safe motherhood. Next slide. So when it comes to safe motherhood, let's move on. Safe motherhood is one of the components of reproductive health. And reproductive health is the textbook definition that when I ask my students, I'll expect them to say. It's essentially what we're saying is that a person should be very okay in the reproductive system, state of physical, mental, and social well-being, and not just absence of disease in all things related to the reproductive system and its processes. That is reproductive health. This is a concept that came out strongly in 1994 when there was the International Conference on Population Development in Cairo. And from there, reproductive health came out. I mean, over the years, people act as if reproductive health is only concerns women. But then there's actually men's reproductive health also, there's women's reproductive health. And reproductive health is not just a thing for doctors and nurses. I mean, our Honorable Minister is a reproductive health. I was asking whether she's an advocate or an activist. I mean, I've seen her display both sides, the advocacy and then the activism. And that's been effective. So it's not a thing that's just for medical personnel. It's a thing for lawyers, it's a thing for the general public. Reproductive health is one area of health that has enough room for every single person. The general public, anybody at all. You want to do something in health, get into reproductive health. It's so big that there's room for everybody in that. So when we talk about reproductive health, we want to make sure that people are able to have a safe and satisfying sex life. We also want to make sure that individuals or couples have the freedom to decide if they will have children at all, when they would have the children, and how often they would have the children. Reproductive health has a big underlying thing of human rights. Human rights is a major thing in reproductive health. I mean, nobody comes and decides for a person, you will have children, and you will have this number. No, people have the freedom to decide if they would have, when they would have, and how often they would have children. So safe motherhood then is a component of reproductive health. And when we talk about safe motherhood, what we are saying is that a woman who's pregnant, a woman, or let's say a couple, it's either individual or couple, should be able to achieve a pregnancy, should be able to carry that pregnancy to term, should have access to all the care, the best possible care within the context that the person is located. The woman, or both she and her husband, should be able to access that kind of care, the best possible care within their context. That would be able to detect any problems with the pregnancy. And when the problems with the pregnancy are detected, these problems would be treated. And then the woman should have access to safe delivery services, should have access to trained people who will take care of the labor. And after that labor, when the delivery is conducted, this woman will be given a healthy baby that she can go home with. And this is the kind of thing that everybody aims for. But the sad truth is that some of us, because we have been so exposed to the bad side of motherhood, we end up being very careful and very cautious when it comes to things to do with motherhood. I remember years ago, after we had our first daughter, it was one of the days when my wife left her with me and went out. She went to a shop nearby where she used to buy provisions. Then she came back and she was full of smiles and said to the women in the shop, they were all around her, they were all happy and saying, hey, you've delivered, because they're pregnant. Now she was obviously not pregnant again. They gathered around her and said, where's the baby and all that. And she was so happy and actually wished she had carried the baby along. And when she said that, I smiled and said, well, I don't do that. If I see a woman who's pregnant today and tomorrow I see her not pregnant without the baby, I kind of like scout around and I'm wondering, did she lose the baby? I don't want to ask a question and then she begins to cry. But the truth is that the average Jack or Jill on the street doesn't think about that. What we expect is that a woman is pregnant, you see her not pregnant again, there must be a baby. That's what we expect. And that's what safe motherhood is about. That's what we are going to be able to promise the general public. Safe motherhood. And many times we help us, in the area of public health, when we are setting targets, we do things like indicator chasing, where we say that, okay, in this district, last year, 50 women died. So we are going to work very hard and want to reduce it. So this year, we are going to make sure that not more than 10 women die. That's a major jump, isn't it? From 50 to 10. You're reducing it by 40, reducing it by 80%, which sounds very nice when you're talking to people doing math. But imagine that I'm the new district director and I've come here just before you and said, I've looked in the books, and last year 50 women died. And this year, we're going to do our best to make sure no more than 10 women will die. We're going to reduce maternal deaths by 80%. The very educated ones among you are going to clap because it's like, hey, this guy is coming to mean business, he's doing an 80% reduction. Then the village drunk at the back will get up and say, doctor, you've done very well. You know, these people, then he counts them 1, 2, 3, then he counts like 50 people. I know their wives are pregnant. Just tell us the 10 that you want to die. Show us the 10. And then the men can start buying coffee. Then it suddenly dawns on you that the target to have is that no woman should die. The village drunk shows you that that is the target that you should have. Not 80% reduction. However big 80% looks, show us the 10 that you want to die. And who wants even one to die? Nobody does. So that's what safe motherhood is about. So these are some of the things that we want to do to ensure safe motherhood. We want to make sure there's health education. Even when women are not pregnant, and when they are pregnant also, they know how to take care of themselves, how to take care of their pregnancies. We want women to come for antenatal care whilst they're pregnant, coming to the clinic, being seen by midwives, being seen by doctors, so that any problem with the baby can be detected, any problem with the woman can be detected, and the woman can be treated. We want women to have skilled attendants at delivery. You know, the reality that we are faced with is that there are some parts of this country where we don't have health centers, we don't have maternity homes, we don't have trained midwives. So there are traditional birth attendants who work. And we applaud the efforts of these traditional birth attendants. But we also know that these traditional birth attendants are not the best for our women. We mustn't talk as if African women want traditional birth attendants. They really don't. They want to be delivered by well-trained people in well-equipped facilities. When we are not able to get that, then we probably have the traditional birth attendants. But that is not, it's not as if the African woman deserves a TVA. I mean, it's not, that's not it at all. Let's go on. So, in Africa, the sad thing about Africa is this. This is a Chadian proverb. It's a woman who's pregnant has one foot in the grave. And our proverbs come out from the things that we observe. You don't want this kind of proverbs to last. We want them to die away. I mean, Mr. Peter was talking about the obstetrician who had worked in the UK and said he has seen only 2 maternal deaths. I mean, I met by that time he must have been, he probably must have been around over 50, his mid-50s or something there. I met somebody in the US who had never seen a woman die in pregnancy before. And he was approaching 60. And he had been actively working. He had never seen a woman die in pregnancy before. We want to get to a point where there are obstetricians in this part of the world who will also say that I've worked for about 20 years and I've never seen a woman die before. Those are the kind of things that we want to achieve. So when we talk about safe motherhood, it started out in 87 in Nairobi. There was a big conference sponsored by WHO, UNFPA, and all that. And that was where they said maternal health is neglected. So we need to do something about it. And they set a target. I mean, the kind of health indicator target that I just said we shouldn't be setting. That they're going to reduce mortality by 50% by the year 2000. They didn't achieve it. But one thing that was achieved was that maternal health became a major agenda item. People began to talk about mothers and the need for mothers to be kept alive, the requestable. And from that conference, that's where the whole TVA thing came about, which we wouldn't go into now. But it's a good measure to put in place where there are no trained midwives, but we should aim to get trained midwives out there. You see, it's a whole business case. If a TVA is enough to save the life of a woman, why should we train obstetricians? I mean, it just doesn't make sense to spend money and get me to take 5 years to be trained when you can get a TVA to do it. Like, TVA is a stopgap measure. And that's what we should realize and know that the ideal to aim for is to have midwives and obstetricians, they're well trained, who can save the lives of mothers. The other thing that came out from this was the at-risk approach, where it's like a woman comes and then we look through her history. I mean, has she had a cesarean section before? Is she short? Has she had a difficult pregnancy before? Has she got a health problem? Then we label her as high risk. So we say the high risk women must make sure they come to hospital. The low risk women can deliver anywhere with a TVA, with whoever. Then this was done for a period. I mean, you guard that high risk woman, everything is in place, you are on your toes around her, then she coughs and the baby drops out, and the baby is crying, and she turns over and she goes to sleep. Then the one that you labeled low risk, you hear some horn blowing and she's brought in. She bled. And she's kind of like dying. So what's the thing that came out from the whole safe motherhood intervention was that we learned that TBAs are very limited in what they can do to prevent maternal death. We also learned that some high-risk women don't have complications. And the stark truth is that many of the complications of pregnancy cannot be predicted. If it were possible to predict, obstetrics would be very easy. You just gather all those women, you count them, and as the complications can be dealt with them. But many of them cannot be predicted. But the good news is that when the complications happen, about 99% of them can be treated, and the women will be fine. So the majority of maternal deaths are preventable with treatment. So we are not trying to do something that's impossible. Even though we cannot predict the deaths, we cannot predict the complications, and even some of the complications are not preventable. When they happen, if the treatment is there, we can get things going. So every pregnancy, labor and delivery should be seen as high risk. It's after the woman has delivered and everything is fine, then you say that that was a low risk pregnancy. You don't label pregnancies low risk before the whole thing has happened. You don't do that so that we don't have a false sense of security. Now, one thing that we're talking about now is MDG 5, Millennium Development Goals. And MDG 5 seeks to improve maternal health. The target is that we're going to reduce maternal deaths by 75% between 1990 and 2015. And the target is to have 90% of women, minimum, delivering by a skilled birth attendant, being seen by a midwife, an obstetrician, a doctor who's been trained to conduct deliveries, or a nurse who has been trained to conduct deliveries. That doctor who's trained doesn't have to be an obstetrician. That nurse who's trained doesn't have to be a midwife. But then skilled birth attendants, the belief, because it was noticed that countries where large proportions of their women were delivered by skilled birth attendants had much lower maternal deaths. So the magic bullet that we are like chasing is every woman delivered by a skilled birth attendant. So when we come to maternal health in Ghana, please. Yeah. I mean, when we do what we call verbal autopsy, go to people, talk with them and ask them, what is it that resulted in the death of a woman who was pregnant? You'll discover that about 24% of the people say that the woman died from bleeding. That's hemorrhage on the far side. About 24% died from bleeding. And if you really want to go through it, though the 11% who died from abortion, there's also bleeding involved. You understand? So we say that this 24, and maybe up to half of this 11, I mean, blood helps solve the problem. That's one. And when you go to the hospital and the diagnosis that we make, it's not that far off from what people say kill them. We have 24% dying from severe bleeding, and then we have 13% dying from unsafe abortion. Now, we said that our aim is to reduce maternal mortality by 75%, isn't it? These are the trends in Ghana. In Ghana, recent things published by the WHO shows that our graph is going in the right direction. It's just not moving as fast as some of us would like it to move. But the good news is that it's going in the right direction. We've been able, between 1990 and 2013, to halve maternal mortality in the country. So there has been good work by the ministries of health, the different governments, the healthcare workers. Things are improving. We just want this graph to kind of like crash down and hit zero much faster. So in 2013, when we look at the record, we had over 3,000 deaths in the country. We're told that roughly about 8 women died per day. And this is a statistic that is kind of like that we need to change. You see, if we in Ghana, if we got this room full of about 70, let's say 70 for a round number, 70 girls who were aged 15, 70 girls aged 15. I actually have a daughter who's 15, about to turn 16. So if we got about 70 of them in this room, one of them is going to die from a pregnancy-related complication before she turns 49. 1 out of 70. You might think that, well, that's not too bad. If you went to Western Europe or the US, you need about 4,000 of the girls that age for one to die from a pregnancy-related cause. So it's very bad, isn't it? Yeah. It's very bad. I mean, in Western Europe and the US, we fill a room with 4,000 and one of them would die from a pregnancy-related cause. In our part in Ghana, 70 out of the 71 is going to die from a pregnancy-related cause. We need to change that kind of statistic. But like I said, things are improving. So these are some figures for 2010. There was a national assessment of the cost of maternal death, the National Emergency Obstetric and Newborn Care Survey. And we can see that there were 111 deaths from bleeding after delivery. There were 111 deaths. Then there were 83 deaths from bleeding before a woman went into labor. That's the antepartum hemorrhage. And there were like 36 deaths from ruptured uterus. Those ruptured uterus deaths, some of them is just because the woman bled and the surgery couldn't be done on time. So these are the maternal deaths. And we're now going to look at how we can ensure safe motherhood with blood. So when it comes to blood and safe motherhood, we can say that about 24% of maternal deaths are due to bleeding in pregnancy. And 80% of that 24 is from bleeding after the woman has delivered. So if we need to mount a guard, it has to be around the time of delivery. And that's why the intervention that WHO is talking about now is skilled birth attendants. The danger time is at the time of delivery. And we need to set up the guards then. I mean, our women are doing very well. They come for antenatal care. And our women value their pregnancies. You just need to hang out at Korle-Bu, the maternity block, and see them come as early as 6 a.m. and sit there. And some leave as late as 3, 4, just for somebody to come and touch their tummy and say the baby's fine. Why does she do that? Because she values the pregnancy. And because she values the kind of service that is provided. But when labor strikes, so we're told about over 90% of our women come for 4 antenatal visits. When it comes to delivery, it's roughly about 70%. Maybe because when labor strikes, the woman is no longer the one who takes that decision. Somebody else is taking the decision. Labor comes without warning. As for antenatal, you know it's going to happen. So she plans and she comes. But labor strikes without warning. She misses out the skilled birth attendant. At the time when the guard needs to be placed there, there's no guard. How dangerous is bleeding during delivery? All this thing we're talking about, that's about 25% of a quarter of the causes of maternal death is due to bleeding. How dangerous is this bleeding? See, the pregnant uterus, when a woman is pregnant, blood flows through that uterus at a rate of 500 milliliters of blood, so about, let's say, 1.5 Coke bottles at that speed per minute. The woman's whole blood volume is like 4 liters when she's pregnant. So if the woman begins to pour after delivery in front of you, and you panic, you don't know what to do, you're kind of like frozen. What can I do? And the way the blood can freeze you. Well, within about 7 minutes, to a different kind of freezing you have, should be dead. That's how fast it happens. 7 minutes. So when the bleeding starts, everyone is on red alert. People are screaming, they are pushing things aside just to save the life of this woman. So a woman bleeding after delivery could be dead in 7 minutes if no action is taken. So how do we ensure maternal survival? There are different stages that we can do it: before pregnancy, during pregnancy, and during delivery. Before pregnancy, let's make sure that our women are in good health. Good food, good hemoglobin levels. Let's take good care of our women. Let's make sure women are in good health before they deliver. And during pregnancy, let's make sure our women come for antenatal care. And then when they come for antenatal care, they are given iron tablets. Let's make sure they take those iron tablets because it helps build the blood stores. And then, when our women are pregnant, we should donate blood. We must make sure that there is blood sitting in that blood fridge every single time. When you were in a medical school, there was a question that was a trick question that one of our hematology lecturers used to ask us. He used to ask us that which is the rarest blood type. Then you stop and you try to do all the percentages, and some say it is A, some say it's AB, some say it's O, and whatever. Then after we've all said it, he said the rarest is the one that you need now, which is not there. That's the rarest blood type. The one that you need now, and it is not there. I mean, just before this meeting, I was in Mr. Tete's office, and there was somebody who needed blood, and there was none in the blood bank out here. So Mr. Tete called his friend at 37, and they're driving down to 37 to pick that. At that moment, that was the rarest blood type. No matter all your statistics, that was the rarest blood type. So we need to donate blood so that at any time the blood is available. If we don't donate blood, at this time when the women are pregnant, we are preparing in case there's an emergency. We don't wait until the emergency happens, then we begin to donate the blood. During delivery, having skilled birth attendants helps because they know what to do. When the problem happens, they know exactly what steps to take. And then when the woman comes in, she's in labor, the blood is taken for grouping and cross-matching to make sure that things are fun. Let's move on. So, when the woman begins to bleed, what things do we do in terms of action? We give medication to make sure that the uterus contracts. The womb has to tighten up. When it tightens up, it closes all the vessels through which the blood flows. So we give medication, some through the veins, some there's some tablets that we can give now that cause that to happen. We check and make sure the placenta has come out. Because if the placenta is there, it's partially separated, the woman could be bleeding. We check if there are any tears, and if there are tears, we quickly repair those tears. And we do everything we can to keep the uterus tightened up. I mean, we are rubbing the uterus, we are pressing it, we are continuing to give an infusion with the medicine in it. And then you can do all this. If you don't replace the blood loss, you're going to lose the woman. So replacing the blood loss is the number one thing. You say the woman is bleeding, let's send for blood whilst we are doing all these things. And then the blood comes, we give the blood, we replace. But if you are trying to replace the blood and you are not doing these other things, that also wouldn't work. So you are doing all this and you are replacing the blood, and sometimes you might need to do surgery. So if we don't have blood, there's a limit to what healthcare workers can do. If we don't have a blood storage facility, but we have blood there, it's a waste. People have donated the blood and we don't have a blood fridge. We don't have a facility like this that we can store the blood. Then it increases the delay, because then a woman delivers here, needs blood, and and you need to go to another place to get the blood and bring. And if there is no blood donation, we all sit back, then we are increasing the risk. The 1 in 70 that I said, they are causing it to climb higher. And we don't want to do that. And every blood donor is a major lifesaver. You might not know it. I mean, we all sit back and dream of ourselves being heroes. I mean, I've done something, I've saved somebody's life. Just donate blood. You are a hero already. I mean, every blood donor is a major lifesaver. I read in a documentary that the lady said she didn't know whose blood saved her life. But that person, wherever he or she is today, has saved her life. Every blood donor is a major lifesaver. Let me look at the next slide. So this is what I was saying, that for Western Europe and the US, their risk is 1 in 3,800. And Ghana, we said, is 1 in 66. The whole of Sub-Saharan Africa is 1 in 39. 40 African girls, age 15, one of them will die from pregnancy and its problems. Next slide. So I'll end by telling you a story. Lives can be saved. Lives can be saved. This is the last one. There was one night when I was on call at the Obsangani unit in Korle-Bu. And we're there and they rushed this young girl in. And she was bleeding. She had had a baby and she was kind of bleeding that I described to you. So we rushed in and did everything that we could. And she was still bleeding. So we took her into the theater. Let's go operate and try and see what we can do. And we asked for blood. It was not that much blood. I think I probably got about 2 units or something. We went in and had to take out a wound, which is a sad thing, but then that was what we needed to do to save it. At the time I finished the surgery, there was still a bit of blood oozing. Did the best to kind of like get it dry, but I knew it wasn't totally dry. But then we had to close up, so I closed up. The anesthetists then put her on some mini ventilator, and I hung out around her for about an hour, 2 hours. She was breathing a bit, and I had to go. Went home and came back early the next day, and that's the kind of time that you come in and you get to the entrance of the labor ward and you're first looking around. Is anybody crying somewhere? Okay, nobody's crying. Are people kind of like looking at you with eyes that are like, oh, you really worked, but nothing's come out of it? You're not seeing any of those eyes. Then you walk quietly to the room where you left her, and then you peep in, she's still there. And she was there. She was there. She was still breathing on that ventilator. So got to the anesthetist and we moved her to the intensive care at the second ward. And as time went on, realized my tummy was kind of like growing bigger. And I knew why it was growing bigger. I knew it was blood that was collected in there. Talked to a senior colleague and said, this lady is still collecting blood. Do we open up? And he said, Richard, you don't open up. If you open up, you can't close. You can't close. There's nothing much you can do. Just replace the blood. So we were regularly going to the blood bank, we get plasma, we get blood, and we replaced. And this lady survived. I mean, the staff at the blood bank were very cooperative. I mean, my house officer was excellent, regularly getting the blood. We gave the blood, kept on. She survived. She began to talk and she could really talk. I was there with the times that she was going on and on. I was like, you're really fortunate that you can still talk. And we later discharged her. She came back for a postnatal care. About some weeks later, she brought me sugarcane. She brought sugarcane and said, hey, doctor, get it. Now, about some years after that, was it not too long, probably about a year or two after that, I got talking with the lady who was my house officer then. And what she said was that as far as she was concerned, that girl was dead. That girl was going to die. And all she was doing was that she was really feeling for me that when this girl dies, this guy's going to be a wreck. The way he's kind of like put his everything into it. And that was why she kept running to the blood bank and getting everything. She was trying to save my life so that at least when the girl dies, I would know that it will be dragged. And she probably went to the blood bank and told the people that if you don't give this blood, my boss is going to die. and the people responded. But the truth is that despite how she felt, and despite how the lab staff at the blood bank felt, if there was no blood, if nobody had donated, there was nothing they could have done. I mean, they would feel for me that my heart is feeling this, even if they don't feel for the girl, they'll feel for the young lady who's out there. But the blood fridge is empty. The donors are walking on the streets not caring. Then we don't have safe blood to be able to save a mother's life. So, what can each one of us do? Every single person here, me, you, your friends out there, your relatives, your church members, your enemies, everybody. There's one thing that we and our enemies can all do together. Each one of us can give blood to save a mother. Let's do that and we'll get somewhere. Thank you.
I think it's enough. Let's give him more applause. Honorable Minister wants to ask for permission. So we'll ask her to give us the closing remarks. Then the question time will flow in.
Yeah, thank you very much. I apologize, I have another function, so I have to run off. Richard, you've done it again. You've done it again. A very brilliant lecture. We've learned a lot. And I'll repeat what you said. For me, that was the highlight of your lecture. If there was no lab. I'm happy you gave us this human story, your personal experience as a doctor and as a gynecologist and obstetrician. I also remember working, I was in Form 3 in secondary school, and for holidays I would volunteer at Korle-Bu Hospital because my mom was a matron at the medical block. And so I worked a few times at the maternity. So at age 15, I saw women delivering. I used to use that tube to listen to the heartbeat of children. But for the fact that I'm very weak in mathematics, I'm sure I could have been a doctor or a nurse. The lecture has re-emphasized the need for us to sustain supply of blood and for us to be ambassadors for our national blood service. We need to be ambassadors. We need to donate blood to save the lives of our mothers who are sustaining and replenishing human beings on earth. Women play a very critical role in making sure that the future generation is assured. We have the future generations. And what Korle-Bu Hospital and what the service, the blood service is asking us to do is to help to donate blood. If there was no blood, this woman, this girl would have died. If there was no blood, the woman we saw in the documentary would have died. So though I'm scared of needles, I'll come here next week and donate blood. And I'm hoping each and every one of us will donate blood. This is very important. Government, we can do all that we need to do. In fact, the numbers were 740 women dying per 100,000 live births. Now it's scaled down to I think 350. Yeah, 350 per every 100,000. And we actually saw the graph. The numbers are going down, but we need to do a lot more. And we all have a collective responsibility to make sure that the government of Ghana and the blood service has safe blood. We all have mothers, we all have sisters, we all have wives, we all have girlfriends, and we all have secret admirers. Let's make sure that, because we may like some, and we haven't been able to tell them, but it's work in progress. But let's make sure that we save the lives of our women, and let's donate. Let's keep it up with the blood. And like I said, Madam Director and Doctor, I can't see him. Yeah, Doc, please keep it up. Keep it up with the public education, and we're very grateful to Metro, to TV Africa, Visat, and UTV, TV3, how could I forget you? We're very grateful to you for coming and also for projecting this so that the wider Ghanaian community would also learn about this. I know it's being streamed live too, so we're very grateful to those who are doing it for the documentary and all that. Ask as many questions as you want to ask. There are several doctors here, but the critical thing is if there was no blood. So please, let's donate blood. Thank you very much. Good evening.
I didn't get the opportunity to thank her, but she's left. So thank you, Honourable Minister. Now, time for questions. Maybe some of you have some peculiar questions to ask Prof. Let me see the hands of those who want to ask questions. I'll count them. 1, 2, 3, finish. Okay, thank you.
First, I would like to say a very big thank you for our professor for enlightening us on issues of safe motherhood and blood donation. We've learned a lot, and my question is about reaction. On few occasions, even though clients are given blood that have been cross-matched, occasionally we witness reactions. I want to find out whether that reaction, there is no way it can be detected whilst doing the cross-match. That's my question for now.
Can we take another one? Okay. Another one.
Prof, mine is on the components of safe motherhood. You mentioned about 1, 2, 3, 4, 5, 6, 7 things. The last one, you mentioned something like post-abortion care. I know in Ghana, abortion is illegal. Why is post-abortion? I don't understand it.
Right, thanks. With the reactions, yes, there are some that one can't predict, but then they are rare. It's not, I can't give you a percentage. I mean, those in the hematologists could give you a percentage, but I would say that it's probably even less than 1%. It's a very small percentage. And usually, to be able to detect that, what we advise is that you don't just start doing a blood transfusion as a doctor and you walk away. You start, then you observe what's happening. And if you do that, you will detect those reactions very early. Many times when it's run into a problem, it's because we've checked the paperwork has been done and we put the blood on and then we walk off. Then by the time we come back, the person either has rigors, has developed a rash and all that. But if we stay for that first 5-10 minutes of the blood going, we'll be able to fix this and it wouldn't result in any major problem. But it's a very small percentage that happens. So once the blood is screened through here, we should all, everybody who's here should walk out and tell people that the blood that is from here, that is transfused, is safe. It's safe blood. Now, post-abortion care, what we mean by that is that, see, there are women who have miscarriages. They have miscarriages. I mean, usually when we use the term abortion, everybody's thinking of an induced abortion. You go to a place and you ask for them to terminate the pregnancy for you. But then there are women who have pregnancies, and somewhere along the line, without them doing anything, they lose the pregnancy. That's a miscarriage. And after that miscarriage, sometimes everything doesn't come out. And the woman still needs to come to the hospital and get care. So that we refer to as post-abortion care in one instance. There are other women too who go out and have unsafe abortions. Abortions performed by people who have not been trained to do it, or performed in places where it should not be performed. Then they end up with some problem and they come to the hospital. The care that we give them also is post-abortion care. And that includes giving of antibiotics, giving of pain relief, and counseling them about the use of family planning methods.
I hope your questions have been answered. Any more questions? Last question, then we call it. There's going to be a refreshment, so glue on your seats. Before we leave, you'll have something to take.
Prof, when you were talking about the donors, you mentioned the voluntary donors and the family replacement donors. Yes, we are in Accra. You get out of the sub-district, and then the family replacement donor, some sort of metamorphosis, becomes a paid donor. Then the black man is confused to stop it or to allow it. What do you suggest we should do? I mean, the family member is not ready to donate. Without taking that blood, we'll lose the mother.
Well, I would say my opinion on this is that we should take every opportunity to recruit voluntary donors. And if we discover that person has been brought to donate blood, it's a person who's actually negotiated with the family and is collecting some money to donate blood, well, let's let the person make that gain from that first donation. But then let's sit down with that person and tell the person some of these things we've said here, and probably get the person's next donation to be a voluntary one. So I think we should look for opportunities to always recruit voluntary donors. And maybe the market is amongst those paid donors who come about. I mean, those are just a few thoughts I have on that.
Thank you very much, Prof. We have a raw deal of a need for us to donate blood. And in our midst, we have some voluntary blood donors among us. We need to organize them. The voluntary blood donors, wait, let me see. Yeah, oh, I mean it. Clap for yourself, clap for yourself. Yes. We have some who have 3 times, 6 times. And we have Sis Akosia. It's a black advocate. Sis Akosia. Can we to see you? Yes, she's the one who was talking about black in the documentary. And then we have Mr. Eddie Mondo. Let's see. There was once the first hashtag Adanu. And then we have somebody again. Second to say, oh, he's here. Yes. How many times have you nominated? 8 times. Yes. I said something, said, give land for those 69 times. Yes. Give life for those who give life. Our fathers give life. So we all need to, in fact, when Prof was speaking, I was sitting down saying to myself, is that so serious? Is that so serious? When he said that women who need blood, they are not giving their blood within 7 minutes, they'll die. That's 70. So even the black people who are in our list, whenever the request comes, 7 minutes, do the wedding. Yes, don't delay at all. So let us all work. Those who want everyone to be a donor, and if you cannot talk to somebody about blood donation. And on that note, I want to thank everyone here for coming. And I pray that whatever we listen here will not take it only home into our bedrooms, but we'll share with our families, in the marketplaces, schools, everywhere we see ourselves, so that we advocate for blood. And also, it goes to Professor Richard M.K. Adanu. Let's give him a round of applause. The articulate man, he presented the lecture. And then the way he was able to convince even me, all of us here, to donate blood, I think may God bless him. And finally, I want to thank the pressman, our head of the Study Area Blood Center, for allowing us to use his premises, and then the director for the sample service, and everyone who is here. We are all important. We are all very important. And I pray that God will richly bless you. And whenever we hear about, yes, Mamaye, shall we clap for them? Mamaye are, our close collaborators. Whatever we invite them, they are supporting us immensely. They are making it to stop maternal death and children death. So, because it's related to blood, they are always working with us. Mamaye, may God bless you and continue the work we are doing. Yes, finally, I want to thank everyone. Whenever you hear that there's something about that donation, let us not stay at home, but let us all contribute so that you can go and donate blood, or call a friend to go and donate blood, so that this thing we are seeing, it should come to zero. No more death when somebody is in labor. The drink is in, so shall we bow for our closing prayer before we drink? So shall we pray? Shall we pray? Our gracious King, we thank you so much. We call on your name when we started. You've been in us. You've spoken to us. Let us apply what we've learned so that we can sleep more life there. What we are hearing elsewhere is that no maternal death. We want this to happen in Ghana. But we say no more maternal death in Ghana. Because we've heard it and we've applied it, and that's come to be. Lord, when we stress on here, we pray that you guide us and give us lovely messages wherever we're coming from, and let us advocate for blood. And out of it all, if any soul is saved, we know that God will recognize us in your kingdom. These and that blessings we ask in the mighty name of our Lord and Savior Jesus Christ. Amen.
Amen.
Thank you all. Sit down and get refreshed. And we hope that next time when we call you, you'll come again. God bless you all.